This conference will now be recorded.
If you want to see, sit down. Okay, so we'll be talking about the second part of the anal canal today. This will be the last in the group of lectures for the anal canal. And the first one will be the benign condition. We talk about benign conditions. And the benign condition will be touching upon would be some of the important ones. And they would be post-anal dermoid. And I think we talked about the differential diagnosis yesterday. We talked about the fistula in ano, the palatal sinus, the post-anal dimple. I don't think we're touching on that. That's a very benign condition. Doesn't require any kind of major discussion. Anal fissure, proctalgia, uritis ani, and of course the hemorrhoids. Right. First, let's talk about the palatal sinus. And we talk about the palatal sinus. Basically, we understand it is there in the intergluteal cleft. But that's not the only place where you can find the palatal sinus. The other sites too, and they are number one, the axilla, the umbilicus, and the interdigital cleft. That's basically the cleft of the upper arm. It's also known as the jeep driver's disease or the barber's disease, basically because it was very commonly found. When discovered for the first time, it was very commonly found in jeep drivers who used to drive for long distances, and barbers who used to work from day to night cutting people's hair, and they found that these hairs would lead to sinuses in the interdigital clefts. So initially it was believed to be congenital, but there's a lot of evidence which says no, it's not congenital. It's basically an acquired disease. And why? What are the evidence in favor? Number one, a congenital disease would not appear commonly for the first time at the age of 29 years. That's the most common age when it manifests itself. Number two, it's only seen in hairy men. Number three, when you find these hairs inside, these are dead inverted hairs. I mean, they don't have, they don't have any follicles to them. So these are dead hairs which are inverted inside the sinuses. And in the wall of the sinus, you will not find any hair follicles. Right? The shearing force and the friction between the buttocks, basically what's happening is, why was very common in the jeep drivers? Because in jeep drivers, when the jeep used to have that upheaval kind of a motion on uneven surfaces, then the two gluteal regions used to work against each other. So there was a differential movement between the two glutea, and that led to a generation of friction and shearing forces, which used to propel these dead hairs into that cleft, right? And then, of course, there's infection relation to hair when you find these sinuses. So these are all evidences in favor of being acquired rather than a congenital disease. So what is the pathophysiology? Why does it develop at all? One, the inverted dead hair collected in the clefts, they tend to get sucked in. I just now told you the shearing force. So it tends to suck in the hair. And when the hair is sucked in because of the force, then it is basically propelled because the end is sharp. So that it used to be propelled inside the skin. It used to create a breach in the skin, and the hair used to go inside the skin, right? Now, the second thing that you find is that when the hair goes in, it leads to a generation of a superficial, chronically infected tract or multiple tracts, all in the midline. And they used to run cranially. They never used to go caudally. So it always goes cranially. The pointed tip of the hair that penetrates the thin, fragile skin of the interdigital web. That's what's happening throughout the day in the case of barber. What about the umbilicus? Umbilicus, no, it's a very deep recess, and that whenever a hair gets trapped inside, it tends to go deeper and deeper down because of the movement of the abdomen during the respiratory cycle, right? So that used to suck in the air there. So in all cases, it's basically the inverted dead hair. It gets to get sucked in, or it creates a minor breach in the skin and subsequent movement to deeper tissues, right? The symptom of palatal sinus, we all know, they could be asymptomatic. The person comes to you saying that, look, I've got a tiny hole there. So what is it all about? Or there could be a history of recurrent suppuration in the intergluteal cleft, or a suppuration in the intergluteal cleft, or recurrent suppuration in the umbilicus, one of the common causes for umbilical sepsis. So let's talk about the gluteal region, right? Now, the local signs are there, but the general signs are minimal. The patient doesn't have any sign of inflammation in the form of fever and so on and so forth. Malaria is not there. But here you find a local suppuration in the form of redness, and you find a generation of pus. Now, either you find a single opening, or if it has been there for a longer period of time, you'll find multiple openings in the midline in the intergluteal. That is very, very characteristic, and that forms one of the main methods of differentiating between a fistula nano and a palatal sinus. So this is always midline, and it always tends to go up. And number three, it is always found in between the sacrococcygeal joint and the tip of the coccyx. The fistula doesn't have any of these bindings. It tends to go caudally into the anal region, and it can always be found away from the midline. There's a paramedian pushing to there, and always tends to go caudally, right? So the differential diagnosis I said just now, Fistulino number 2 hidradenitis suppurativa is again a condition usually found in the apocrine glands, which are there in the region of the anal margin. Okay, now the treatment, the patient comes to with an acute abscess, just like an abscess elsewhere. You just drain it and pack it, and then go ahead and do a stage excision after 6 weeks when all signs of local inflammation have subsided. That's one. Number two, the patient tends to come to you in the chronic stages. Then you can do a marsupialization, a curettage of that whole cavity. Right? That curettage could either be a physical curettage, or you can do a diathermy excision of that particular area. Number three, what you can do is you can excise the whole primary closure, just like in a fistulotomy and fistulectomy. You tend to excise the sinus, or you may lay it open. So the first one, you're laying it open, and the whole of the wall is being curettage. Here, what you're doing is you're excising it with primary closure, and you're waiting for, or you can just leave it open and wait for a secondary healing to occur. So excise, close, or leave it open for secondary healing. Now, if you find that you have created a lot of gap and a large defect has been created, then you can do a flap reconstruction by a local flap itself, or you can take a flap from some distant site, the Caridacus or a Bascom's. I'm just telling you these names. You don't need to go to the details of these, what these flaps are, or the most commonly done, a Limburg's flap repair. Complications of a pulmonary sinus are number one, it can behave chronically, and a recurrence is very, very common, either because you've left something inside, which is a true recurrence, or because of the scar that you created in that intergluteal cleft. Your surgery created in the intergluteal area. Because remember, those shearing fossa are still there. They're still there. So that can now act on the scar, leading to a tension on the scar and leading to opening up of the scar. So you can have a scar breakdown. So true recurrence is leaving a part of the sinus behind, or it could be a scar breakdown, or it could be basically because of a fresh infection in that particular area. The third complication could be a long-standing pilonidal sinus can always give rise to generation of a malignancy, right? Now, pruritus ani is a very, very common condition. And just remember the 5 P's, and the 5 P's: parasites, piles, and you got the polyps, you got the psyche, and you got the pus. Psychological, psyche, psychological, and you got the pus. Pus basically as a result of bacterial infection or parasites. The 3 common parasites, either threadworm or scabies or pediculosis. The 3 common causes of giving rise to pruritus, especially in the children age group, right? But it could be there even in the old age group. Or you can have grade 2, grade 3 piles, which tend to secrete a lot of mucus, and that leads to a generation of pruritus. Then another cause could be allergy, or you can have a skin disease in the particular area, and chief among them could be psoriasis, contact dermatitis, lichen planus. And then the treatment of the cause is no major issue, but then it is a major issue in the sense that you keep treating the condition and the patient keeps coming back to you, look, I'm not having any kind of a response, until you nail it on the head and you find out what the exact reason is. So you can give a steroidal cream that is just a symptomatic relief until you find out the exact cause, and if you do, then treat the cause, keep that area clean, and temporarily use a steroid cream. And then of course you have to treat one of these conditions if they are there, like for example parasites or lichen planus or psoriasis, and so on and so forth. But coming to one of the most common conditions, that's anal fissure. Now anal fissure diagrammatically would be found in the area of the anal, and that is basically, remember, somatic nerve supply, this is autonomic, and because the somatic nerve supply out here, it is basically a very, very painful condition. And this is how it looks like. See, this is how it looks like. Now, this is basically a condition which is very, very painful. The scar is always linear in the anodome proximally up to the dentate line. See, this is the dentate line. So it's always up to the dentate line, it doesn't go beyond that, not proximal to that. So it's there only in this particular area. And what is lying in the floor? Lying inside the floor is the lower end of the internal anal sphincter. So IAS lies underlying. So these fibers are running like this, circular fibers, and that is underlining the floor of the IAS, right? The floor of the fissure. Now, the sex, male and female, Male, it is more commonly in the posterior part. Almost 99% of them are basically are seen in the posterior part, and females, they're more commonly anterior, almost 10%, and that's usually because of the weak perineal body. So it's more commonly anterior. So don't go with the impression in mind that all of them in the females are all of them are basically anterior and now they're posterior. No, that's not true. But more commonly anterior are found in females and less commonly in males. Now, etiology, if you look at the etiology, the primary etiology is a primary shearing force because of the hard stool. Now, basically, it is working. So, rectum is coming out here and that is going posteriorly, right? And because of the posterior uh, angulation, we know about that anorectal angulation. So, the hard fecal mass is creating a shearing force out here. So posterior angulation canal, a high basal sphincteric tone of the internal anal sphincter, constipation, repeated diarrhea because of constant movement across this particular area, whether it's a diarrheal stool or it's a constipated stool, vaginal delivery, and ischemia, they all work together to give rise to the shearing force, ultimately leading to the generation of an ulcer in this particular area, which we know as a fissure nail. There could be secondary cause. So this is the primary cause, the more common cause, but there could be secondary cause to it, like for example, a Crohn's disease or HIV infection, lymphogranulovenereum. We can have tuberculosis, common cell carcinoma. So these are all secondary causes which can manifest in the form of a acute or a chronic fissure nano. The chronicity of fissure nano, so this is basically the primary. The chronicity of fissure nano, the acute variety you just talked about, the chronicity is basically because number one, a repeated acute fissure with reduced vascularity and venous edema. There could be persistent increase in internal anal sphincter tone, fibrosis of that particular sphincter, and chronic constipation, all working towards the scenario where you have a repeated generation of acute fissure nano or a usual generation of fibrosis in that particular area, right? Now, the pathophysiological event. So what is the pathophysiological event? Number one, that tear which is occurring out here in the somatically supplied area leads to severe pain. So the person tries not to defecate because this pain is not only defecatory when the hard mass or the diarrheal stool is moving across this fissure, it is going to irritate the somatic nerve ending. So very painful, and that pain persists even in the post defecatory pain. That could be there for almost what, an hour, 2 hours, 3 hours, whatever, right? Now that leads to what? That leads to a spasm of this muscle. Now what does the spasm do? It tries to close the edges so that the exposed nerve endings are no longer subjected to the movement of the fecal content, whether it is diarrheal or it's solid. And that is what the body is trying to do. So the internal anal sphincter is basically trying to constrict itself and trying to oppose the two edges of the ulcer together, so that it doesn't offer a floor with exposed nerve endings to the moving fecal content. So the person tries not to defecate. He learns not to defecate because he knows when he goes for defecation, he or she goes for defecation, there'll be severe pain, right? So person learns not to defecate. Now this spasm for a long period of time has got a number of problems to it, a number of offshoots to it. Number one, the spasm leads to venous obstruction. Veins which are draining this particular area, and that would lead to edema at the edges, lead edema to the cranial, edema to the caudal area. Cranially, it leads to hypertrophy anal papilla. Caudally, it leads towards sentinel skin tab because of gradual generation of a papilla. That is basically because of the venous hypertension, because of venous obstruction. So there's edema, and that edema gets converted into a distinct sentinel tab. At the same time, the margins become edematous. So the edematous margins cranially manifesting an anal papilla, caudally as sentinel skin tab. And in addition to this spasm, it becomes persistent. That means a chronic fissure nano. It is converted from spasm into a fibrosis. So see what are the effects of this spasm. The effect of spasm is because of the edema, because of conversion into fibrosis, and all this leads to the chronicity of a fissure. And that's why when you look at the history of such a patient, he'll give you a history of regular constipation with frequent passage of hard stools. But remember one thing, not only hard stools, it could be recurrent diarrhea also. Even a recurrent diarrhea can give rise to a fissure. Number two, the patient gave a history of a direct trauma to that particular area. Or it could be secondary to episiotomy in females. That's why 10% of these fissures in a female is anterior, right? Or it could be because of secondary cause, we just not related the secondary acute fissure. So the signs and symptoms are very, very simple. Number one, painful defecation, persistent post-defecation pain. The blood can also occur. Hematochezia is another presenting feature. And why hematochezia? Because these edges, especially when there's venous hypertension, they bleed. They bleed. And this bleeding leads to a streak-like bleed or a streak-like hematochezia along the sides of the fecal mass. So if the fecal mass will have a streak-like bleeding. That is the more common type. But that's not the only kind of hematochezia. Remember that. You can also have a hematochezia which resembles a hemorrhoidal bleed, but which would be painful. In hemorrhoid, it is always painless. Here it will be a painful bleed, right? So more commonly streak-like blood, or less commonly as a bleeding in the form of drops, or even in the form of splash in the back. Okay. Now, the sentinel tag will always be a sign which tells you that this is basically a chronic. It has become a chronic fissure, right? Now, the diagnosis is very simple. You will find the inspection. So on the inspection, what do you see? A sentinel tag out here. And what do you see at the cranial part of the sentinel tag? It is guarding something. That's why the name sentinel. That's why the name sentinel. Why it is guarding the lower edge of a fissure. So this is a breach. So you find the breach when you separate the edges. So when you separate the edges of the anal verge very gently, you'll find this. Basically, you'll find what? You'll find the fissure and you'll find the central tag. Right? DRE is not possible. Proctoscopy is not possible. Why? Because there is increased spasm and it's very, very painful. Right? But it can be done under anesthesia, which it should be done. Why? Because I just not told you that it could be a secondary kind of an acute fissure in it. So it could be having some pre-existing higher up disease. So that has to be discerned. So if you're not able to do a DRE proctoscopy even after application of xylocaine for a long period of time or local anesthesia for an adequate period of time, even if that is not possible, then always go ahead and do a examination under anesthesia. Biopsy would be required in those patients where there is a suspect area, especially cranial to it, like for example, a secondary fissure. And there you have to differentiate from all the disease that we just not talked about. In addition, Kaposi, syphilis, chancroid, etc., they all have to be kept in mind. The treatment is very simple, conservative. It is simple, but it's not very easy in the sense it's not very easy for the patient. And you have to have a high fiber diet with fiber supplements to make the stool soft, formed and bulky. Stool softeners have to be taken regularly. If the patient passing a hard stool, if the patient having diarrhea, they should give an anti-diarrheal. Drinking more water helps to prevent hard stools and aids in healing. Apart from that, what is most important is that prior to defecation, at least 10 minutes, you have to apply a local anesthetic application at least 10 minutes prior to defecation. Once you do that, then the patient goes for defecation, and post defecation, the patient should have a warm tub bath for an adequate amount of a cis bath. Now that is minimum 10-20 minutes and should be taken minimum 2 to 3 times a day, even without defecation. It is always advised that every time you go defecate, take that. Do a cis bath. But if it is not, then even then otherwise 3 times, right? So that is basically working by counter irritation, right? And it has to be lukewarm water. Remember, it's not should be boiling water. You know what is happening with the boiling water when you start dipping your anal region into boiling water, right? So once you've done that, that helps to relax and soothe that particular area. So it relaxes the anal sphincter. In addition, you already relaxed it with the local anesthetic. And that is why subsequent to your bath, it should always be a reapplication of lidocaine, that is a local anesthetic, and local antibacterial. So it is a 3-part cycle. You give a lidocaine or a local anesthetic, whatever you want, a local anesthetic, sitz bath, and then reapplication local anesthetic along with the antibiotic. Right? So that together completes the cycle of a complete sitz bath. Right? If you don't want to give a local antibiotic, you don't want to give a sitz bath, then you can use local dilators in the form of dilitazine. You can have nifedipine or nitroglycerin ointment. They can all be used to relax the anal sphincter muscle, which all relax the internal anal sphincter, right? They can all be used. But one of the problems with these local applicants is, which are dilators, they also create a lot of headache in some persons, and that is why it's not applicable or it's not easily acceptable by all patients, right? But coming to the treatment, which is a surgical treatment, one could be just use a Botox injection, botulinum toxin, which is again a relaxant for the smooth muscle, so it relaxes the anal sphincter for you. Agree, that's one. But what is more conventionally done is a very carefully done anal dilatation. And why is the anal dilation working? Number one, it will remove the spasm, and more so if there is fibrosis, it's going to break the fibrous bands, right? So it breaks the fibrosis. And what you should do is, when we were studying, you were taught to put in three fingers, and dilate to the maximum. And you see what was going to happen? The risk of having incontinence was not only 30%, it went up to 70%. So now what we know is a gentle dilatation with only three fingers. Remember that. It should never be a six-finger dilatation. That also never forceful, right? We were taught that you should keep your forearms like this and a right angle out here and exert as much as you do. You can well imagine what's going to happen. So don't do that. Don't do that. So it should be gentle anal dilatation, only three fingers to break the fibrosis. But even then, you have some degree of incontinence in the postoperative phase. Or you can do dorsal sphincterotomy. And how do you do a dorsal sphincterotomy? What do you have? You have basically what? You have the transversely running fibers out here. So just give an incision out here, simple, through the bed. But then you can well imagine what's going to happen here. This would be an area always subject to the bacterial contents of the fecal mass. So having an abscess in this particular area is very, very common. And that's why the most common complication of this method of a dorsal sphincterotomy was a perianal abscess. Because you're creating in the bed of the fissure, and that fissure is there until it heals, that particular cut is always going to be under the contact of bacteria. Right? The second could be, don't cut it there. Don't cut it there. Do a lateral sphincterotomy. Cut it out here. There could be two methods of doing it. Either go from here and do through the white line. Remember white line we talked about yesterday? That is the intersphincteric area. Which intersphincteric area? Between the internal and the external. You approach from there. As soon as they go inside, you see those white running fibers. Cut it and then re-stitch it. That's one method. The second method is a lateral blind sphincterotomy. Put the blade from here. It should be 11 number blade. You put it from here, and this blade goes like this, and then you turn it at 90 degrees. And then one finger inside the anal region, you tend to cut without breaching the mucosa. That's very, very important. So when you're doing the closed method, right, closed or open, when you're doing by the closed method, you have to be very, very careful that you don't damage the mucosa while you're cutting the internal sphincter. But what is now being touted is probably not a very good method, lateral sphincterotomy. Why? Because number one, it is more or less inadequate most of the time. You try to be convert to adequate, you breach the mucosa. Or if it is an open method, you stitch the mucosa back, then it can always lead to an increase in risk of perianal hematomas, abscesses, and mucosal damage with later formation of fistula and needle. So all these three complications with the lateral sphincterotomy: hematoma, abscess, and fistula. Three common complications with it. And that is why you can do a fissurectomy with primary suturing. You can do a dorsal fissurectomy with primary suturing. Now what I'm doing out here, what I'm doing is I'm cutting and then I'm freshing the edges and I stitch it back. So that could also be a good method to do, right? So fissurectomy with primary suturing, or fissurectomy with an anal advancement flap. And what is an anal advancement flap? Again, let's see this. You cut it out here, you freshen the edges, you got a large area. So take a flap from here and you bring it here and you stitch from here to here. So that is an anal advancement flap, which is now covering that fissured area which you have excised. So fissurectomy with anal advancement flap, fissurectomy with primary suturing. See the word ectomy. So you're excising the fissure out here. Here what were you doing? A sphincterotomy, you were cutting the sphincter. You were not doing anything to the fissure. In fissurectomy, you're basically also excising the fissure by freshening the edges, right? So this is basically how it looks like. Dorsal and open lateral. This is basically lateral. See the dorsal. I'm cutting the edges, the sphincter, and then I'm stitching the edge. This is basically lateral. This is the fissure. I'm not doing anything with the IES out here. What am I doing? I'm approaching from here and rotating the see this 11 number blade. I'm rotating and then I'm cutting the sphincter. So that is basically a lateral sphincterotomy This is basically a dorsal sphincter. Okay. Now, the few terms that you should be familiar with. One is anismus, and there's synonyms to it. It is also known as spastic pelvic floor syndrome, anal sphincteric dyssynergia, pelvic floor dyssynergia, dyssynergic defecation, and paradoxical puborectal contraction. All of them would give an idea what we're talking about. This is basically, we're talking about a dyssynergy, or we're talking about discoordination, a non-coordination between what? Between the pelvic floor muscles and the external anal sphincter. So basically what's happening out here? It is a functional obstructed defecation, failure of normal relaxation pelvic floor during attempted defecation. Now, normally when you want to defecate, what should happen? The pelvic floor should relax. It should allow the fecal mass to descend. It should allow some degree of descent of the anal canal, of the anorectal region, that should be basically made patent. Here what is happening? When the external anal sphincters are trying to contract, trying to propel the fecal content out, what is happening? The pelvic floor muscles are not contracting, they are not relaxing, they're contracting. So there is a focal dystonia. What's happening? There's a discoordination or non-coordination between the pelvic floor muscles and the external ES, or the external anal sphincter. And that is what leads to what? A painful defecation, a constipation. It doesn't allow the fecal mass to go. So what happens? It remains in the rectal ampulla. The painful defecation, constipation, and tenesmus to a great extent. And that fecal mass which remains in the rectum, because the patient is not able to pass that fecal content, it keeps on accumulating, leads to what? Fecal impaction. And is more commonly found in women than in men, and sometimes associated with sexual abuse. Normal defecation involves what? I told you, relaxing of both. But here what is happening? One is relaxing, the other is contracting. So the symptoms are simple rectal inertia. The rectum is not working. Here also anismus, it's not working. Why? Here it's not working because of a non-coordination. Rectal inertia is not working because the forceful contraction is not there. So in one, it is non-function of the propelling muscles. In the other, it's a non-coordination between the propelling muscles and the relaxing muscles. Is that simple? That's simply to make you understand. The other term that you should know is proctalgia fugax or levator syndrome. And what is proctalgia fugax? It is a disease which is very commonly found in doctors. It's found very commonly in doctors. See, often in doctors. See what's written? Often in doctors. What is this? This basically an excruciating cramp-like pain occurs just for a few seconds to start with. It's there. It's so much that you try to double over. You try to not to express that pain. The pain occurs in the anal region or the perianal region, and caused by what? By the pubococcygeal muscle, which is what? The part of the levator ani which is going and inserting itself into the coccyx. That is the anococcygeal reflex. That's where it's going to insert itself, the levator ani. And is sudden, excruciating, intermittent, episodic, and very severe self-limiting. That's very important. So it's self-limiting, occurs for a few seconds, a few minutes, goes away. Then you're absolutely all right. You don't know what happened suddenly. And then only to have it repeated more and more frequently over a period of time. So initially it used to occur less a few seconds, then it will occur more frequently. Often it occurs at the night time when you sleep and you wake up, or when you're defecating. You must a number of you must have experienced it. When you're trying to exert, suddenly that pain appears, and then you stop exerting, and then it disappears, goes away. Anxiety attacks, ejaculation. These are all instances when you have this cramp-like proctalgia pain. Anxious and seen in stressed out patients, often in doctors, right? Often in doctors. So chronic form is known as levator syndrome. So when you're talking about the chronic form, you call it levator syndrome. Acute form, you call it a proctalgia fugax, right? The treatment is simple. It has to be a psychological or psychiatric treatment. Amitriptyline is one. Salbutamol inhaler, which relaxes the smooth muscles for you, and Botox in the pubococcygeus muscle, because that is the muscle which is creating the whole problem. There's few other terms we should know of. Number one is parcopresis and encopresis. Parcopresis is basically a psychological disorder, and more accurately should be known as psychogenic fetal retention. Now, this is basically you are shy. It's also known as the shy bowel. Why? Because you have got a problem that you do not want to defecate in presence of a number of persons. Now, what does that mean? That basically means you're not going to defecate. I'm not going to defecate keeping the bathroom open. Usually occurs in weddings. or you usually go, you're gone to attend some kind of a function where you have to stay overnight, and you're shy that people see you going into the bathroom. That is a shy bowel syndrome. So you have to have a certain level of privacy. Your privacy is such that you don't want others knowing that you are really gone for defecation. That is the level of privacy that you require. So it is basically the inability to defecate unless you have a certain level of privacy. So the level of privacy has to be there, right? And that level of privacy varies from person to person, right? Now, one person could be happy enough to just go into the bathroom closet and he's happy. The other would be that, look, nobody should see me going into the bathroom. That's your level of privacy, right? So the level of privacy differs, and that's why it's known as shy bowel syndrome. Now, it has to be distinguished from embarrassment. One is embarrassment. You're embarrassed to go in front of others, right? The other is basically the level of privacy required. So it's basically a fine distinction between the two. There's a fine distinction between the two. And that's why the treatment is psychological. Encopressor, on the other hand, so parcopressor is basically a psychogenic fecal defecation problem, right? So fecal mutation. This is basically also a degree of incontinence. And what kind of incontinence we talk about? We talk about involuntary defecation, especially associated with emotional disturbance or psychiatric disorder. And how does it occur? Often seen in the form of soiling of your undergarments. You take some psychiatric drug and you also are soiling up. So you basically would be known as encopresis. And that is often seen when you got a fecal impaction. It dilates the whole of the rectum wall, and from the side of the wall it trickles, and that soils a growth. So that liquid stool from the sides of an impacted stool creates encopresis. A parallel to this situation could be drawn with a CBD stone, just to make you understand much better. In a CBD stone, why do you have intermittent jaundice? Because the CBD stone is impacted at the level of the ampulla. Now what happens? Keep on dilating the CBD, so the walls fall away from the stone, and now the bile trickles from the side of the stone and re-enter the duodenum. So that jaundice disappears, or it may not disappear, it decreases for a certain period of time. So similarly out here, the impaction leads to what? The falling away of the rectal wall away from the impacted stool, so the liquid stool now trickles from the side and soils the growth. Is that clear? That's to make you understand. So encopresis, right? Abscesses around the anal canal. We talked about the anal spaces around the anal rectum. Just to repeat that, this is basically the perianal space. Two parts to it. Remember, the marginal and the real perianal. Then higher up you got the ischiorectal, you got the intersphincteric, and you got the supralevator. Right? Just to make you understand, just to remind you. And remember, last time we said circumferentially communicating spaces. That means if you have it on one side, we always chance of having on the opposite side, or you have it in the midline posteriorly, always chance of having a horseshoe abscess. And that you have to understand why. Because you drain less in an abscess on the right side of a ischiorectal abscess, and you forget to look on the left side. You find there's induration on the left side, and you think it's just an induration by itself. Let's not worry about it. What has happened? You left an abscess on the left side also. So you have to remember that there are certain spaces which communicate on either side. And they communicate through what? They communicate either through the postcenal space, that's the most common, or they can communicate through the intersphincteric space, or they communicate in the presacral space, right? So around the rectum are the presacral space, the supralevator, the postcenal space, the communication ischiorectal space, and the intersphincteric on here, and to a certain extent the perianal through the superficial postanal space. So remember, this space communicates the superficial postanal, this space communicates the deep postanal, this communicates that the intersphincteric, and the supralevator also communicates. This communicates in front of the sacrum. So remember, whenever you got a perianal abscess or you got abscess in the region of the anal canal, you always look for an abscess on the opposite side. Otherwise, this patient will keep coming to you that, look, I'm still having this the pus still coming out through the incision that you made, right? The causes. The most common is the cryptogranular theory, and remember yesterday day before yesterday we talked about the anal glands, which are commonly there in the intersphincteric space, or they could be found in the submucous space, or in the internal sphincter or external sphincter. Just to remind you, I was very emphatic about it that the anal glands are not only the intersphincteric space, they could be found at varied positions. So what happens is the abscess starts, the infection starts in the glands, and then it can spread on any part. I'll just show you, right? Apart from the cryptogranular theory, which is the most commonly accepted theory, there will be other causes also. It may not start in the anal gland. It could be starting in any of the submucous other spaces. In what cases? Like for example, a patient who's diabetic, a patient who's got AIDS, HIV infection, or specific cause like for example a submucosal abscess. Starts in submucosa because of trauma in the submucosa, like for example post-sclerotherapy or post-hemorrhoidectomy, you did a hemorrhoid in a patient, or you have been given injection in a particular hemorrhoid post-sclerotherapy, and you have a generation of abscess submucous space. Or let's say the mucocutaneous or marginal abscess, like for example infected hematoma, or a issue rectal abscess, like for example a post-boil or a deep penetrating injury in your buttocks, right, in your lower gluteal region. So what happens? There's an abscess primarily there, or you got a furunculus in that particular area, you got an abscess there, or you have pelvirectal, like for example any cause for pelvic abscess. Like for example, you can have a Crohn's disease, you can have a tubercular abscess, you can have a neoplasm. So any of these abscesses in the pelvic area behind the peritoneum would be communicating on either side. So they could be all because, right? Now it starts as a cryptograndular, starts here. Now what happens? See, intersphincteric. It can spread here, it can spread here, it can spread here, right? So it can spread 95% are from cryptogranule. So remember, the cryptograndular theory is the most commonly accepted theory. Why? Because 95% of these abscesses always originate from the cryptograndular source, right? Now from here it spreads to other spaces, right? So from these spaces, see, it has spread. Where? Supralevator. This is the levator ani. Gone up. Supralevator. What is this area? What is this area? Issue-rectal. Gone to the issue-rectal space. What is this area? The marginal area. So perianal, it could be issue-rectal, supralevator, or it could be submucosal spreading in this particular area, right? And see, this is basically the area where the anal duct is opening. See the pectinate line, the suprapectinate area, and that is where it opens. The web space out there, or the sinuses, that's where it's opening. And through the spaces, it can also spread to the opposite side. Starts here, spreads to the opposite side, right? So you have to remember that. So if you look at these spaces again, we just talked about that. In the terms of commonness, perianal abscess, which include the marginal perianal, is found in 60%, and the second common is the issue rate, 30%. So together they make 90% of the abscesses in and around the anal canal or the anal verge. So 90%, 60% in the marginal perianal and 30% in the issue rectal. Together make it 90%. The rest of them would be what we just not talked about. Okay. Now the anal abscess, the presentation is variable. You can have a closed space with longitudinal muscle extensions. Like example, yesterday I told you, day before yesterday I told you that those spaces jutting out from the lower end of the longitudinal muscle create closed spaces, and that gives rise to very severe pain. So excruciatingly painful if it is a marginal abscess. Other spaces, the local sign symptoms may be less, general symptoms would be much more, right? So there are general symptoms and later on local symptoms in the other spaces. Local symptoms are site dependent. That's what I talked about. Marginal, more pain. Issue rectal may be less pain over a period of time. Okay. The management is number one, especially in deep lying abscesses, there has to be examination under anesthesia. That has to be done, right? Adequate drainage is a must. Remember, don't be minimally invasive as far as abscesses are concerned. Remember that abscesses have to be a drainage and adequate, right? Don't be minimally invasive. Just say I'll get a very small opening through a 11 number blade, and that should be enough. I've drained everything out. But what have you left behind? The granulation tissue. So remember, adequate drainage. De-roof the abscess cavity. Always de-roof it so that that constant drainage is always there. And then do a gentle packing. You're not doing a packing for stopping the bleeding. That's not what you're doing. The gentle packing is basically to ensure that the edges do not come together. Remember, whenever you're packing a particular cavity in the human body, as far as we surgeons are concerned, number one indication is creating the opening for a longer period of time. And number two is always to stop blood, right? So here it's not a question of bleeding. So that is why it is said gentle packing. If it had been for bleeding, it would have been known as tight packing. Is that clear? So we're doing a gentle packing. Always send the pus for culture. Always look for a fistulous communication, which is perhaps one of the most important things when you're draining a perianal abscess. Remember that. Why? Because perianal abscess, more often than not, always have a fistulous communication deeper down. That fistulous communication has to be looked for, preferably at the time when you're draining the abscess. But the problem is that you may not find a fistulous tract at that point of time because of edema. So if you are there, if it is possible, do it at that time by gentle probing. If not, don't do anything. Don't do anything. Just de-roof and go in for a second stage fistulous or a fistulectomy, starting what you want, right? So always look for a fistulous communication, more substantiated by finding coliform organ in the pus culture. Now, if there had been no connection with the anal tract inside or the lumen, there should be no finding of coliform organism. So in the culture, if you find any coliform organ, entropocci and like organism, be sure that there has to be fistulous communication. If I find only streptococci or staphylococci, you can rest assured that there's no communication inside. But once you find these gram-negative coliform organisms, then you be sure that there is fistulous communication, which if it is not possible at that point of time, you will have to tackle it later, right? And that's why I said, if possible, treat the abscess like a fistula always, if it is possible. If you look at the fistula in anal, because that is an offshoot of the abscess, right? Now, if you look at the overview, number one, the tract is always the granitic walls, and there have to be two openings because it's called the fistula. So one inside the lumen and the other outside of the skin, right? And usually is in the internal opening is the regional pectinate line, unless until it's basically opening inside below the pectinate line as seen in the marginal abscess. And why inside? Because if we look at the cryptogranular theory, where is the duct opening? The duct is opening in the region of the pectinate line. That is why, by and large, more often than not, the internal opening is always in the region of a pectinate line, right? The classification has to be known. The presentations are very simple. If a patient comes to intermittent discharge of blood or pus, and often a passage of feces or passage of flatus, that is not very common, right? It could be primary, secondary, or solitary, or multiple. Let's see what is happening. Now, remember this figure from the last two slides. Now, what is happening out here? This pus bursts. It bursts and takes a root here. That means this is basically the external sphincter, right? Now it comes from here and drains out here. Or the ischiorectal abscess bursts out here. So it creates a fistula like this. Or this bursts out, it creates a fistula like this. In all these communication, where is the communication? Inside, or in the pectinate line, or in the pectinate line. Or it could burst from here to here, right? And based on that, you are basically got the classification, and that classification is the Parkes classification. And remember, when you talk about the sphincter, remember this, always in relationship to the external anal sphincter. Sphincteric basically here is external anal sphincter. And it's very simple. What? Intersphincteric. We talked about the longitudinal muscle and EAS, intersphincteric. Or it goes transsphincteric to the parts of the external sphincter. Superficial, then you got the subcutaneous, superficial, and deep. It is going through the external anal sphincter, or it is going above the external anal sphincter, suprasphincteric, or it is going through the levator ani, or known as extrasphincteric. So simple, either in between, through, above, or through the levator ani. Intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. Okay, so that is very easy to remember. That's the Parkes classification. And among all these, the two common ones is 45% inter and 40% transsphincteric, which makes your job easy. Why does it make a job easy in 85% of cases? Because in these cases, you can easily tackle these fistulas without the danger of creating incontinence in the postoperative phase. Why? Because you're leaving behind the main continent mechanism, the levator ani and the deep part of the sphincter. That's why 85% of patients, you go ahead and do some kind of any kind of treatment. We talk about what treatment you do. You would not be creating a incontinence in this patient, right? 15% you have to be very, very careful. So that brings us to the symptoms. Intermittent discharge of pulse, fluid, blood. We all talked about that. Intermittent cessation. So that's very common. The patient will tell you, look, I've had this discharge, then for 2-3 months I'm absolutely all right, or let's say 15 days or 1 month I'm absolutely all right, and then I again develop pain, local area, and then sudden passage of blood, and my pain disappears. A very, very characteristic history of a patient with fistula. And why does it happen? The fistula's mouth closes, so the discharge starts accumulating, the pus starts accumulating until the pressure becomes so much that pain appears, and then the pressure increases and it bursts through to the confines of the fistula, and there's sudden relief of pain. So the local signs disappear. If they're general signs, they disappear, which are usually not there, and then the discharge ceases. And the patient feels I'm absolutely all right. And at that point, if you advise surgery to this patient, you say, you're talking to your hand. I'm absolutely all right. Why do you need surgery? Until he gets those same symptoms, let's say 1 month, 2 months, or 3 months later. And then he understands, look, the doctor was right. So that is basically a cycle of events in these patients. And that's why if the patient comes to in quiescent stage, this patient will always give a past history of recurrent lapses. Right? Or he will give history of some precipitating event, like for example, a fistula nano, a fissure nano which was treated, or the patient had been treated, given injection for, let's say, hemorrhoid, and then he said, I had this injection about 3 months back. I'd gone to Gwalior, I'd gone to Jaipur, two very, very common places where they go for injection therapy for hemorrhoid. One is Gwalior, the other is Jaipur. So he went there, he had this injection, and now he said, look, I'm having this kind of discharge. So some precipitating event, if you take a proper history, that may be present, right? Often you can have multiple site discharge. Remember that, multiple site. I'll just tell you what to examine in these patients, right? So multiple site discharge, then you start thinking of some general disease or some other disease, precipitating disease, like for example, tuberculosis, Crohn's, or malignancy, right? Now, complex fistula in ano, how do you define a complex fistula in ano? The term is not very commonly used. It's now very commonly used, not now. So basically, these are with tracts extending, number one, above the level of the dentate line. Number two, multiple tracts. Number three, ano-vaginal fistula. And number four, fistula associated with Crohn's disease or tuberculosis. So all these are basically those which would be known as a complex fistula ano. So if you ask about the definition of complex fistula ano, that would be number one, above the level of the dentate line. Number two, multiple tracts. Number three, ano-vaginal fistula. And number four, fistula associated with Crohn's disease or tuberculosis. The second term is secondary fistula in ano. And I said earlier, secondary fistula in ano basically has to deal with some other pre-existing primary disease, like for example, a rectal trauma, a Crohn's disease, anal fissure, a carcinoma, radiation therapy, actinomycosis, tuberculosis, and so on and so forth. So that primary disease is there, and it has led to the generation of a fistula. Okay. Now, class 3, you already talked about that, and this is basically the same diagram again. So this is how it looks like. This is basically a solitary fistula nano. So when you're doing a clinical examination, first thing that you see is the site and the number of openings. You see the site and you look for some number of openings. So site, what do you see the site? You see the site as relative to the anal verge. The nearer it is to the anal verge, the more chance of having it as a low fistula in anal. And if you have a site very near to the anal verge, it is more likely to be an intersphinctic fistula, very close to the anal verge. The farther it is, the more the chance of having a high fistula, right? So if there are multiple openings, don't go ahead and don't jump into an operation or an operative procedure for that particular fistula. Always think of underlying disease and always do a biopsy, for God's sake. Never forget that. Complex fistula in ano, a biopsy is mandatory. Only then go ahead and do some kind of a proper therapy or a final therapy, right? So multiple, always do a biopsy, always indicate it. Number of openings and the site of opening. Type of discharge is again important: pyogenic, bloody, clear, watery, or a frank pus or fecal content is more commonly found in multiple fistula in ano. Why? There's a larger tract, right? The type of discharge. Then you palpate the tract. You start palpating here between two fingers. One finger could be inside the anal canal, the thumb could be here. You do that, right? Now, if you are able to feel the tract throughout, then it is likely to be a superficial low type. If you're not able to palpate the tract, it has to be a high type. And that is where the Goodsall's rule helps you. I'll just show you what the Goodsall's rule is, right? Then internal opening, it not usually palpable. Put your finger inside. This external opening is well seen. Now you say, let me see the internal opening. More often than not, you're not able to palpate the internal opening. Instead, in the internal opening, you'll be able to feel what? A hypertrophied papilla. So hypertrophied papilla, which is there in direct line with the external opening, could be because of the internal opening. Is that clear? Anal sphincteric tone has to be seen. Probing in a conscious patient should not be done. You want to probe a conscious patient, don't do it. Don't do it. Right? Why? Because it is painful, and the moment the patient has pain, he tends to contract his muscle. and in this contraction of the muscle, now you're trying your force against the contracted muscle. So what are you going to do? You're going to create a fresh tract, and that fresh tract may convert your simple fistula into complex fistula. So remember, probing in a conscious patient should not be done, right? Under anesthesia, it can be done. So under anesthesia, you can do a gentle probing, or else to find the internal opening, you can just inject a small amount of methylene blue or a peroxide, hydrogen peroxide. And then with this dilated part here, dilated part out here, now what are you doing? You're looking for the egress of the blue dye, or you're looking for the egress of oxygen bubbles out here. That gives you the site of the internal tract, right? Now, the Good-Sal's rule. It is not true for all. Remember this. This is very, very important to remember. It is not 100%, but helps in most cases. This is a misconception in the mind that this is going to help in every patient. No, it is not. But most of the patient, it may help, right? So this is the posterior, the 6 o'clock, and this is basically the anterior or the 12 o'clock. Now, and you draw a line from 3 to 9. 3 to 9. Now, any tract found in front and a line drawn at 1.5 inches. A semicircle has to be down out here, right? A semicircle at 1.5 inches and a line, transverse line from 3 to 9, and a semicircle from 3 to 9, a semicircle 1.5 inches. Any opening inside the semicircle and this line, so you're making a transverse line and half a circle. So this is basically half a circle. Any opening inside will always have a straight tract, right? Any opening apart from this semicircle will always open posterior, primarily. It doesn't mean there is no secondary tract. There could be secondary tract. There could be secondary tract to this. One could be going like this. One could be going like this. But primarily the primary tract, right? So beyond a radius of about 3 to 3.5 centimeters, beyond, any opening exteriorly is always going to open posteriorly. If found within this semicircle of 3 to 9 and a curved line about 3 to 3.5 centimeters inside, will always have a straight tract. Is that clear? Is that clear? So that is the Good-Sal's rule. So that is not this is not the total Good-Sal's rule. The part 3.5 centimeters has to be added to it. Okay. So what are the investigation that you like to do? You like to look for the internal opening. I just now told you hydrogen peroxide and methylene blue. You would like to probe, but always do that under anesthesia. But probing is not a very good method of looking for a secondary tract. So what can you do for a secondary tract? Just create a fistulogram. Inject a radio contrast and take a X-ray in 2 or 3 views. It will tell you if you find dye leaking inside the anal canal or inside often in the rectum, you know that's a high type. It's high type. In the rectum, it's a high type. Why should opening in the rectum? Maximum should be opening in the pectinate line. Okay, then it is basically what? A pectinate line opening is basically low type. Anything opening with the rectum is supposed to be high type. The fistulogram, endoanal ultrasound. You have the probe inside the anal canal, or you can do a CT scan, or you can do MRI, which is perhaps the gold standard. As of today, if you want to, or if you ask about the investigation choice for a fistula, it has to be MRI. Why? It tells you all the secondary tracts. It tells you all the edema around the secondary tract. It shows the total course of all these tracts. So that is what you want. That's what you want. So it is clearly discernible on an MRI scan. Really, you can do a barium study, especially in those cases where you have what? Where you have a rectal pathology, like for example, a Crohn's disease or a malignancy. In those cases, a barium study may help you. And also in those cases where you suspect a primary disease, always do a biopsy of the fistula tract. Like for example, a tuberculosis. That's why I said multiple openings, always biopsy. You have a higher disease, always biopsy. Okay. Now what's the management? One, marsupialization. You lay it open, right? A fistulectomy, that you cut the whole thing, or a combination of both. But just remember, what's going to happen out here? 45-40%. You lay it open, no problem. You cut it, no problem. You still got the sphincter mechanism. But let's for a moment think this patient about extra sphincter, or let's say a suprasphincteric fistula. Now you're trying to cut. You cut everything. What do you cut? You cut the whole of the ES. You cut the IS. And what is the patient left behind with? Only the levator NI. You have damaged the sphincter complex. So what happens to this patient? Permanent incontinence. And it's going to curse you throughout your life. throughout his life and throughout your life. So, and suppose if you got a pelvic abscess and trying to cut, what's going to happen? You're going to create an opening from the abdominal cavity out. So remember, 15% of patients, you cannot do a hysterectomy and a fistulotomy. Or in other words, a patient who's got a high type of fistula. What's a high type of fistula? Where the internal opening goes above the anorectal region, number one, or a part of the tract is going above the levator ani. Right? That means the sphincter complex, the tract is going above the sphincter complex. You cannot ever do a fistulotomy or a fistulectomy. You can't do that. You can't do that. So either you do fistulotomy, fistulectomy, or combination of both in those 85% of intersphincteric, a submucosal, or a transsphincteric. The supra and the extrasphincteric can never be tackled by this. And that is where what comes in is a set-on. And there what do? You have a combination of fistulotomy, fistulectomy along with a set-on. Now what does it basically mean? This basically means that part of the tract, let's come back to the question again. Now, I was cutting through this and I've got this problem. Now what do? What I can do is that I can cut this part and then I stop. And instead I put in a set-on out here. I haven't cut the deep part. So I've not damaged the sphincter. But instead what have I done? What I have done is basically I have put in a set-on out here or a thread. I'll tell you what a set-on basically means. So that means there is a partial, I've done a partial fistulotomy, a partial fistulectomy along with the rest of the tract has been dealt with a other method. And what is the other method? That other method is basically a set-on. And the set-on could be either loose or tight, or you can have the various material set-on, or you can have one of the newer methods of management. And what are these? See, this is basically a fistulotomy. There's external opening, you got the anal opening. See this? And you put in a probe and you can cut over this. Leave it open. That is what? A marsupialization. I've cut over this opening. I've cut over this rod, which is traversing what? It is traversing the external opening and the internal opening. That means inside the tract. And if I cut here, it is laying the tract open. Right? So I have done what? I have done a fistula. Here what have I done? Here I have done a removal of a part of the wall. So I've done a fistulectomy out here. Okay, so in fistulectomy, I have removed part of the wall. In fistulotomy, I have laid it open. That is very, very simple. So what are the principles of fistulotomy? I just not told you, intersphincteric, transsphincteric, but not for other EAs or the other methods, suprasphincteric and extrasphincteric, it cannot work. And also in anterior fistulas in females, that means the 10% of patients, you should not do it. Why? You damage the perineal body. So any anterior fistula cannot be treated with the fistulotomy or fistulectomy, and all those fistulas which are suprasphincteric or which are extrasphincteric cannot be touched by fistulotomy or fistulectomy. Here, what are you doing? You're marsupializing. What else? You are leaving the tract open, but you have to remove the granular tissue lining the wall. So you have to curate the granular tissue, right? Trim the edges so that it remains open. It doesn't close up as soon as you cut it. And search for secondary tract. That is very, very important. And how do you know a secondary tract? Once you remove the granulation tissue, you'll always find an area of sticking granulation tissue. You want to scrape it out, it still sticks out there. Be sure that there is the opening of a secondary tract. So when you're doing a curettage, if you find a level of granulation tissue somewhere which keeps on sticking, it does not come on easily, then that is a secondary tract. So search for secondary tracts, lay them open and drain them. Deeper tracts with more sphincter involvement, remember, either fistulotomy, even that is problematic. Then if you're doing a fistulotomy, you should always repair that muscle. If at all you want to do a fistulotomy, repair that muscle. But let me tell you, that's a very difficult proposition. You always land up with complication, so please don't do it. Right? But this is the better method, part fistulotomy and part loose set-on. Right? Fistulectomy, again the same, but the only difference is that here using a cautery or management as for fistulotomy. Right? So this is fistulotomy, fistulectomy. See the figure I told you. I removed everything. The transsphincteric. What is this? Intersphincteric. So I removed this. I removed this. This is either fistulotomy or fistulectomy. Right? With a set-on, I told you about that. A transsphincteric. Now a high transsphincteric or suprasphincteric. What I've done? I've cut this part and the rest I've applied a set-on. Okay, so divided muscle is dotted, that's divided, and this I've left a sit-on inside. I have not damaged this part of the muscle of the EAS. I've left it behind. I've not damaged it. So this patient will be continent, but this patient still has a remaining fistula. So what do I do with it? What do? I put in a sit-on, right? Now, sit-on could either be tight cutting or loose, right? Now, what does tight cutting mean? That they has to be tightly. It has to be tightly. It has to be tightened so that it is now approximating that muscle very well around the deep external sphincter. Remember what have I left behind? The deep inner sphincter. So it has to be around the deep inner sphincter. So what have we done? Open the skin, subcutaneous tissue, internal sphincter muscle, subcutaneous external sphincter. See, part of the internal sphincter. What is this? Subcutaneous. I've cut this, I've cut this, I cut the skin. And what have I done? I've tightened it across what? The superficial and the deep, right? It is periodically tightened. It's not that I tighten it and I forget about it. No, that's not to happen. Over 6 to 8 weeks, I keep on tightening it. So today I tighten it up to a particular level. 6 weeks later, I call the patient back and I further tighten it. Now, whenever you're tightening something, what's going to happen? I'm gradually obliterating its blood supply. When I gradually obliterate the blood supply of anything, ultimately what's going to happen? Fibrosis. So these tight sit-ons, they help by creating fibrosis in the region of the sit-on application, which leads to gradual cutting effect of sphincter muscles and essentially exercise the whole time. So when I've done with the whole tightening, what is going to happen? This whole tract will lay open. But your question would be that obviously when he said I can't cut it, fistectomy, fistectomy, incontinence would happen. Now how is this going to work? Here also incontinence is going to happen. No. Now remember, whenever you got a circular muscle like this, now when you cut out here, it separates. So I've cut here, separates, right? But if I create fibrosis here and here, and then I cut through the fibrosis, this is not going to separate. And that is exactly the function of a sit-on. Sit-on creates fibrosis in a particular area, then I cut through the fibrosis. When I cut through the fibrosis, or the sit-on itself cuts through the fibrosis, the edges are not going to retract. So remember, whenever using a tight cutting sit-on, it helps by creating fibrosis and preventing the separation of the edges of a circular muscle so that incontinence is not going to happen. That's not going to happen. Right? So remember, when using cutting sit-on, even for deeper layers, incontinence does not happen. Look at the success rate for cutting sit-on, 80 to 100%. Right? But long term, this is immediate. If you long-term incontinence, they are there up to the extent of 31. That basically means what? That means that the fibrosis is not enough to prevent incontinence in all patients. 30% of them would be still having incontinence. This is how it looks like. See, this is a cutting sit-on. Sit-on here, sit-on here. Right? This is basically transsphincteric, high. Your muscles only to produce a gradual fistula. That's how it's applied. Now, what is the loose sit-on? See how loose it is? See the looseness? It's not tightened, it's loose. Now, how does that work? This again passing the same track. This is a high what? Transsphincteric, high transsphincteric. But here it is loose. So how does this loose work? This looseness basically keeps the track open. So here it acts as a drain. It is keeping the track open. So whatever is collecting inside, it drains out, right? So it drains out, and because you got a foreign body somewhere, it creates fibrosis in the deep external sphincter muscle. So fibrosis is common to both, but in one it was creating fibrosis by what? By the effect of ischemia. Here it is creating fibrosis by the effect of irritation, right? And once the superficial wound is healed completely, 2 to 3 months later, the sit-on bound sphincter now can be divided manually. So there it was the tight sit-on which was dividing the sphincter for you. Here you are cutting the sphincter once you have let the loose sit-on for almost about 2 to 3 months. Right? Leads to eradication in 60 to 78% of cases. Used as stage fistectomy, just like in the last one, and can be used before advanced flap procedure. So I cut this, and then if I got a wide area, I do a flap procedure, right? So the patients where you got other procedures working, so you can have either a fistectomy, a fistulectomy, or you can have a combination of both, or you can have a combination with a sit-on. Okay, what other things can be done? One, you can have an advancement flap. I just not told you about that. That you cut and create a large opening, you cover it with a local advancement flap. Or you can use glues. Now here what we've done, You put this here, and over a period of time, you find fibrous occurred. You inject glue from here up to here. All infection is gone. So that glue covers the whole fistula and closes it. So you can use a glue, right? Now, the new procedures, one is the lift technique. Basically, ligation of the intersphincteric fistula strap. And here is a novel approach. And what is done in this approach? Do I have a figure for it? No, I don't have a figure for it. So basically, what is working out here is that if you remember, when we're talking about the anatomy. We talk about the mucosa, we talk about the internal sphincter, we talk about the longitudinal, then we talk about the external sphincter. Now, this track is going from here to here. So, if you can dissect in between the internal sphincter and the external sphincter through the longitudinal muscle, then you are looking at the track. So here what you're doing is you're basically dissecting the intersphincteric plane, and you're doing what? You're basically removing all the necrosed anal gland, and you're looking at the fistula and you're tying it towards the internal opening. So number one, you're scraping the whole necrotic anal gland. Number two, in the intersphincteric plane, you're ligating the tract towards the internal opening, right? And you're curettaging the external opening. Simple. Three things to be done, right? So what are you doing? You are basically ligating the intersphincteric tract, close the internal opening, removal of the intersphincteric tract, scraping out all the granulation tissue, the rest of the tract, and the internal opening has to be sutured, right? Okay, success rate almost 65. The second thing which can be done is, along with this, the external opening, you can put in some kind of a fibrin glue, what is known as the plug technique. So lift with plug or lift without plug. The last, which is now the newest entry into the fistula, is the video assisted anal fistula treatment. And this technique involves the use of an endoscope, and you put an endoscope through the whole tract. And with the endoscope in place, you also got a scraper, or you got an instrument which can do a removal of the granulation tissue. So along with the scope, so this is working telescope, and it's got a working port out here. So you gradually reduce inside the fistula, and you're scraping, you're cauterizing, scraping, and then aspirating. So basically what is happening in this patient is that you're looking at the whole tract, you're curating the whole tract, and you're removing it. You're removing the granulation tissue. And when you reach the end, towards the opening inside the anal canal, then using a semicircular or linear stapler to close that internal opening, right? So you close the internal opening, your fistula tract is debrided with a fistula brush, and scraping sent for histopathology, and then a fibrin glue is injected into the whole tract, which closes the tract. But there's a problem with this WAF technique, and that is, if it has got number of secondary tracts, or it has got a curved tract, then that fistula, because telescope, because it's not a telescope which cannot bend, right? It's a rigid telescope. So because it's a rigid telescope, it cannot negotiate the curved tracts. One, it cannot negotiate a secondary tract. So that is where the problem lies, right? So in a simple fistula, a WAF technique works very good for you, but in a fistula which has got number of secondary tracts, or it has got a curved tract, the WAF technique does not work for you. What are the complications of treatment of fistula? As I just said earlier, one, because of a spinal anesthesia or local anesthesia or whatever, a fluid retention, a bleeding could be there, not very common unless until you go very deep inside. A fecal impaction could be there, a thrombus hemorrhoid could be there. So these are all early postoperative complications. A delayed postoperative complication could be there. There's recurrence of the fistula, which is a very common eventuality. And that said, basically, if you're tackling a fistula early in your career, be sure of one thing, always advise the patient. Tell him that, look, you have to get operated second time, third time. This is a condition keeps on recurring. And why? The most common cause is that you missed a secondary tract, or you have either missed a primary tract, you have done an incomplete excision, right? Incontinence, you damage the muscle. Anal stenosis, basically because your excision was such that the margin was excised to a great extent, and that margin contracted, leading toward a fibrous of the anal canal. And then, of course, the delayed wound healing, you create such in your over exuberance that I don't want to have a recurrence. I removed a lot of tissue, which is not really required. So that creates a very large gap. And the patient keeps coming to you for dressing, 1 month, 2 months, 3 months. We have patients who are coming back to us even after 3 months. The wound has not healed. So there would be two things. Whenever the patient has got a healing time of more than 2-3 months, or more than your expected time limit, always be sure to resend a biopsy. And that's why a fistula should always be sent for biopsy. Why? Because that could be a harbinger of of a disease, underlying disease. Like for example, it could be Crohn's, it could be tuberculosis, whatever. So one cause of delayed healing is either an excessive tissue removal, or second cause could be that you have left or you have missed out on some other primary disease. If you look at the recurrence incontinence, standard fistulotomy, recurrence, let's forget the 0%. It's more like 18%. Sit-on use more like 17%. Mucus advancement flap 17%. Incontinence figures about 7 to 8%. Set-on use about 17%. A lift technique gives a recurrence rate of 33%, right? So basically, in all these patients, one thing you can see that recurrence is never 0% uniformly. Incontinence never 0% uniformly. So there's some amount of recurrence or some degree of incontinence has to be there in every patient. The differential diagnosis is very simple, and you have to have hidradenitis suppurativa in the anal region, tubercular, furunculosis, pulmonary sinus, and venereum. They all have to be considered. These are all secondary or the primary cause of your secondary fistula anal, right? They all should be looked for as a differential diagnosis, right? I think we just cover the hemorrhoid. We still got a number of things to cover. I just cover hemorrhoids today. They take about 15-20 minutes. So we talk about the internal, external, the internal. So this is basically just an overview. Let's talk about the hemorrhoids. Now, when we talk about the hemorrhoids, remember last time when we were talking about the anatomy, I told you that you got the two plexuses, the internal rectal venous plexus, the external. And here somewhere you got the what? You got the pectinate line. So above the pectinate line, you got the internal hemorrhoidal plexus. Below the pectinate line in the margin, you got the external hemorrhoidal plexus, right? And I told you about the three cushions last time, 3, 7, 11, and we talked about the extra cushions out here. They're not cushions, they're basically longitudinal folds known as the folds of Morgagni. So these are basically again longitudinal folds out here, and three major folds which have a appearance like a cushion. So they are known as the three cushions. So three consistently placed cushions at 3, 7, and 11. And these are basically formed by what? A rectal veins varicosity, and they have a twig of the superior rectal artery, right? Now, cushions are normal, their varicosity and prolapse is not. So cushions are there. I told you the main function of cushion is what? It gives you a watertight seal of the anal canal. That is one of the major cushions, the major roles of the cushion. It keeps everything together, right? So the cushion is normal, but abnormal cushion is not normal. What do we mean by abnormal cushion? Varicosity and prolapse. Now, internal hemorrhoids, I told you about the dendrite line, generally painless, but once it becomes an external hemorrhoid, so this is basically what? Somatically supplied. So external hemorrhoid is below the dendrite line and it is usually painful. And that gives you an idea of the grades of hemorrhoid we talked about. One is not prolapsing, one it is prolapsing, goes back in, and third grade it is out, and fourth grade it's a complicated. Very well depicted in these three pictures, right? In one, you got the internal hemorrhoid at this place. Second, it is now prolapsing, and when you exert, comes out, goes back in. This is a permanently prolapsed hemorrhoid, and grade 4 is basically a external hemorrhoid. And remember, this classification is not for external hemorrhoid, it is always only for the internal hemorrhoid, right? The causes are the primary hemorrhoids or secondary hemorrhoids. Now, the primary hemorrhoid, the causes that we were taught are now disproved today. So the cause that portal hypertension leads to varicosity, the infection, repeated infection cause varicosity, or the primary hemorrhoid, or diet and stool consistency, or anal hypertonia, or aging. Now, these were all facts and figures which are considered to be important when we talk about primary hemorrhoids in the earlier times. But now they have been all disproved. So basically, what is the current view? The only current view, the only one thing is working, and that is shearing for the rectum cause the cushions to displace caudally. And there is some degree of collagen disorder, and that's why hemorrhoid is seen to run in families, right? So just two views. Number one, the shearing force, and number two, the cushions are basically displaced laterally, caudally, and number two is basically some degree of collagen disorder leading to a disorder at the area where the longitudinal muscles sending out these septae, which are keeping the mucosa adherent, so that becomes loose, and then that leads to a formation of a hemorrhoid. Secondary hemorrhoids, so that is the primary hemorrhoid. Secondary hemorrhoids, we've got a number of reasons. You know, the anal rectal carcinoma, local anal rectal deformity, hypertonic anal sphincter, or the patient has got ascites. He's got increased pressure in the abdominal cavity, or there's a gravid uterus. You try neoplasm, ovarian neoplasm. So all causes which can be leading to a generation of a secondary hemorrhoid. Neurological, paraplegia, multiple sclerosis, bladder carcinoma, so on and so forth. So what are the symptoms? Symptoms are simple. You got bleeding or hematochezia, and that hematochezia is very, very characteristic. It is usually in the form of drops or splattering of the pant. Two things very important. There's always in the form of hematochezia, in the form of splattering of the pant or droplet. Pallor is also one of the very common features, and the patient is so anemic, comes to you, and when you take a history, then that everything comes out. Yes, I've been having this bleeding since I think 2 years, 3 years, 4 years, whatever. Right? The patient presents with anemia only. He doesn't give you a history of bleeding. You have to elicit it. Pain is usually only in external or in prolapsing complicated, right? Otherwise, you don't have any pain in a hemorrhoid. Perianal, painful defecation, and complicated hemorrhoids. So these are all features of grade 4 or external hemorrhoids, right? Lumps at the anal orifice, that history is very difficult. There is something comes out during defecation, then goes back in itself. Or I have to deposit it back. That's how you decide whether it's grade 2 or grade 3. Prolapse, permanently prolapse out there. Anal pruritus again there. Why? Because the mucosa is permanently out there. There's a secretion of mucus, and that irritates your margin, giving rise to what? It is a pruritus, right? Ulceration could be there as a complicated hemorrhoid, thrombosis, complicated hemorrhoid, or grade 4. So all these are presenting features of a patient with internal hemorrhoids, right? Complications, thrombosis occurs, and thrombosis, remember, is most commonly seen in which type? Grade 2 and grade 3. Why grade 2, grade 3? Because it has to negotiate the sphincter every time. In, out. One spontaneous, other, you have to push it. So whenever it's transgressing a particular, negotiating a particular area with tight sphincter, chance of thrombosis always there. So grade 2, grade 3 thrombosis occur. Grade 1 doesn't occur. Grade 4 may or may not occur. Fibrosis, why? Because with gradual infection, if it becomes an infected hemorrhoid, with the passage of time, it converts into fibrosis and they retract, what is known as a fibrous bile or a fibrous hemorrhoid, right? Ulceration can occur because it's permanently out, it gets irritated, or it gets there's injury because of your undergarments or whatever, you rise to ulceration. Gangrene can occur, especially again in grade 2, grade 3, especially in grade 3. Why? It has negotiated a tight sphincter. That tight sphincter gradually cuts off the venous supply, the arterial supply, and gangrene can occur. So that's a complicated hemorrhoid, which usually occurs in a grade 2, grade 3. Grade 3 more commonly. Portal pyemia, infection moving from here into the portal system. How do you diagnose it? Proctoscopy and a digital rectal examination, and of course sigmoidoscopy may be required if you're thinking in terms of a secondary hemorrhoid. So you have a whole list of other investigation. I'm not going to go into the details of those investigation. Depending on the cause that you're thinking this patient to be responsible for hemorrhoid, you go ahead and do the investigation, right? So, but as primarily about the hemorrhoid, you do a proctoscopy examination or a digital rectal examination. The treatment is not so simple. Number one, conservative therapy, we all know, and the conservative therapy is in the form of making the patient non-constipated, make the constipation disappear. Number two, use some venotonics where you want to decrease the pressure in the venous system in that particular area, and you can use local steroidal creams, which are the mainstay of conservative therapy. But then comes the interventional therapy, and one which is very commonly done even outside. That means the patient who go to Gwalior and go to Jaipur, what do they go for? They go for the injection sclerotherapy. That means you are sclerizing, or you're pushing something in where the whole of the pilus mass is now undergoing fibrosis. Or you can use a balanced band ligation, or you can remove the whole of the hemorrhoid, cut it out and remove it. Or you can do a circular hemorrhoidectomy again. Now, basically, what is a balanced band ligation of O-rings or suction ligation? This is basically how it looks like. I've just picked this up from the net to help you. Now, this is basically a cone, and you take see this is the rubber band. You load the rubber band here and try to push it here. And there's a groove out here. The rubber band goes and fits out here, right? Now, you remove this cone. That cone is now removed. So what do you have? You have this in front of you, this part. And now you push an instrument like this, which is a grasper. And with this grasper, see this grasper, and you got the loaded. Can you see these two rubber bands? No O-rings. Now you're grasping this. Now when you're grasping this, now you push this outer cone, rather not the cone. You put the outer sheath here, goes over the pilus mass, and then with the help of this grasper, you push this ring over the stalk of the hemorrhoid. See, this is what happened out here. Now, when it leads to application over the stalk of the hemorrhoid, what's going to happen? Gradual cutoff of the blood supply. That leads to fibrosis of the hemorrhoid. So that is basically a balanced band ligation. The same thing can be done by applying a suction over it. See, this is basically suction. Now that suction sucks the hemorrhoid inside, and the application of O-rings occurs very easily. So either using a suction or using a band ligation, you can easily apply a band over the base or the stalk of the hemorrhoid. That's how it looks like. And then you cause interruption of the venous and the arterial, leading to gradual fibrosis. So that's the band ligation, or applying O-rings or suction ligation, right? The second is more commonly the Albright's technique. And what's the Albright's technique? This is one of the most common, one of the easiest techniques to do. And the Albright's technique basically is injecting a sclerosin. So let me tell you one thing, and that is the injection can be done intrahemorrhoidal. This is the intrahemorrhoidal. The second thing, it can be done at the stalk. You can inject here, you can inject here. Now, which is better? Then normally, if you ask me, this is much better. Why? Because with this injection, it's the sclerosin. How does the sclerosin work? It creates fibrosis. So where the fibrosis is occurring? The fibrosis is occurring where it is occurring at the base of the hemorrhoid. So when it's occurring at the base of fibroid, it is of the hemorrhoid, it's going to do what? Cut down the venous supply and arterial supply totally. If you're injecting inside the hemorrhoid mass, what's going to happen? Here, you're going to interrupt a few veins or a few arteries. This is not total, number one. Number two, inside the vein, if you inject a part of the sclerosin, is going to be pushed into the, washed out into the circulation. So it's going to lead to some kind of a sclerosis defect in the general circulation. That is why, whether it's the esophageal hemorrhage varices or it's a varices here in the hemorrhoidal varices, the injection can be perivaricial and intravaricial. Remember that these two terms are important. Intravaricial basically means inside the mass. Perivaricial means outside around the mass. So the Albright's technique basically can either be intravaricial or perivaricial, intrahemorrhoidal or perihemorrhoidal here, right, in the hemorrhoid, context of hemorrhoid. Albright's technique initially was always a perihemorrhoidal. What do you inject? You inject some kind of a sclerosin. What are the common sclerosins used? Number one, 10 to 20 ml of 0.5% polytoconol, right? To a 30 gauge needle, 5 to 10 ml in each pipe, to a total of 10 to 20 ml, never more than that at one sitting, right? That means if you got 3 main masses, you're injecting how much? 15 ml. If you got 2 masses, inject 20 ml, right? What are the alternatives to polytoconol? The earliest was oily phenol in almond oil, which we used in 70s and 80s. We always used phenol. We never had polytoconol. We didn't have this at that time. We never knew about polytoconol, right? So about 30 years back, 40 years back, they never had polytoconol. They used to use phenol almond oil. Or you can just use simple 50% dextrose. Now, there are a whole list of sclerosins which can be used. But at this point, just remember these three, right? What the site? I just now told you, intra and peri. Now, the problem with peri is simple, and that is it can either be most superficial or it could be deep. Now, if you're in the right plane, and what is the right plane? The right plane is what? The submucosal. That's the right plane, right? This is the right plane. Either you can go to the muscle or you can inject it intramucosally, which are both wrong planes. Now, intramucosal injection can easily be seen by what? A local area of blanching, sudden blanching. And that blanching tells you what? That you injected the wrong plane. What's going to happen? That mucus is going to slough out, leading to what? Leading to an ulcer in the particular area and subsequent generation of infection. So that is a wrong plane. You recognize now that you're wrong plane because I've injected in the mucosa. There's been blanching of the mucosa, and that is going to create a problem in this patient. Or I go too deep. I'm injecting into the muscle. And what's that going to do? Immediately the patient has got some degree of pain. So remember one thing, that if the patient has pain during injection, you're in the wrong plane. If you have blanching, you're in the wrong plane. So what should happen? When you give a perihemorrhoidal injection, there should be lifting of the mucosa. It should be lifting, right? It should not be blanching. It should be lifting. That's how you know you're in the right plane. So remember that. The right plane is very important as far as a perihemorrhoidal injection is concerned. Inside the varices, again, you know that it is very easy. You don't have that problem of a deep or a superficial injection. That problem is gone. So either intrahemorrhoidal or perihemorrhoidal. Perihemorrhoidal is slightly more, has to be governed by a number of variables. That's basically the superficial and deepness has to be confirmed. Now, when should we repeat the injection? Now, fibrosis takes anywhere from 3 to 6 weeks. So call this patient back only after 3 to 6 weeks. Ask the patient about the bleeding. The patient more often than not will tell you, my bleeding is either minimized or it's gone. You do a proctoscopic examination, you find some remnant, repeat it. And maximum you can repeat it 3 times. Beyond that, the fibrosis is so extensive that the needle will not go in. So after 3 injection, 3 sittings of injection, you'll not be able to inject it any further, right? So 3 episodes, 3 sittings of injection and repeated only after 3 weeks. And every time, never more than 10 to 20 ml of the scroll that you want to use. Then comes the open hemorrhoidectomy, and either you can have a low Milligan-Morgan method, and low Milligan-Morgan method basically means that you're going through the skin. This is basically what? The skin. So this is the skin, the anal verge, and this is basically what? This is basically the hemorrhoidal mass. Here's the verge, and then here you got the anal margin. Beyond the verge, you got the margin. So you're going through the anal margin. See, the cut is made through the anal margin. And through the anal margin, what do you see out here? The internal sphincter, the circular fiber, the internal sphincter. So you go beyond the internal sphincter, and then you reach the stop. How do you know that? Because once you go beyond the anal sphincter, only then you're going to reach the stop. So to reach the stop of the or the pedicle of a hemorrhoid, you have to go beyond the anal sphincter, the internal anal sphincter, which you see like a transverse fibers or circular running fibers, pearly white. The typical description is pearly white fiber. Once you go there, then you ligate it. And ultimately, once you're done with all the 3 primary hemorrhoidal masses, it should look like this. It should look like a clover leaf. It should never look like a cauliflower. The moment you have your end result as a cauliflower, be sure that you've done a butchering job, not a proper surgeon's job. So it should be very clean cut. It's very clean cut and appear like this. These are bare areas. These are bare areas through which you can see the muscles, and it should be in a shape of a clover leaf. Cauliflower means all kind of shapes out here. You've cut whatever you wanted. So that is a very badly done hemorrhoidectomy. So low type, why low type? Because I'm going to the anal margin. This is the anal margin, then I'm going beyond the margin, then I reach the verge, and then I go beyond the internal sphincter. Is that clear? Now, the other could be a high or a Ferguson's type. Now, high or Ferguson's type is what? I don't go through the margin. Now, where am I entering in a Ferguson's type? In a Ferguson's type, where I'm entering is basically, see, in the one type I was going through here, Milligan-Morgan method. So I entered from here, I went through this internal sphincter underneath, and then I went here and I tied it out here. In the second is I don't go through the margin, I don't go to the verge, I go inside, and from here I go out here, right? So in one I have gone from here, in the other I have gone from here. Now you know the difference. Can you notice the difference? In one I've gone through the margin, in the other I've not gone through the margin. I've just entered beyond the proximal to the anal verge. So that is basically. Oh, sorry, I'm sorry. I've run the opposite way. So in this, the high type, I've not gone through the verge. I'm going through the. I've not gone through the margin. I'm going through the verge. Can you see this? Again, the internal sphincter. Here, minimum amount of margin. So I've gone through the verge and then I ligated and then I close it. I've closed it. I've closed it. So this is basically a closed hemorrhoidectomy or a high hemorrhoidectomy of the Ferguson's type, right? But there are now other newer methods of doing a hemorrhoidectomy. Now one, MIPH, minimal invasive procedure for hemorrhoids. Then I got the transanal hemorrhoid dearterization plus mucopexy. I'll show you just a few slides of that because these are new terms and which are new methods which are minimally invasive. You don't create problems for this patient and the pain is minimal, because one problem with all kind of hemorrhoidectomy is the pain, the postoperative pain. Then you can do a hemorrhoidal artery ligation operation, which is similar transanal hemorrhoid dearterization, known as a halo procedure. You can burn it out with a laser. You can burn it out with the ultrasound. You can burn it out, or you can do a photocoagulation with the infrared. You can do a photocoagulation with the bipolar electric current. So all of them are basically targeted what? Number one, you're ligating the artery, and if possible, trying to burn out the varicosity. Now see, this is basically the infrared coagulation. This is an infrared coagulator. This is the pilus mass, and you burned everything out. That's the coagulation. This we already talked about, the injection and the banding. Mucopexy. Now, what is mucopexy? Now, when you've done a ligation, suppose I've done a ligation of the artery. Now, what happens? The pilus mass is still there. I've just ligated the artery. So everything is hanging. The patient is very perturbed. You said you will do an operation, not done anything. The whole pilus mass is still coming out. So what do? You drag the whole of the pilus mass up and try to basically suture it to the upper part above the pectinate line. So the whole pilus march, which is coming out, I have a ligate the artery. I know that within 3 to 4 months this would disappear, but the patient doesn't know that. The patient says, "Look, I have everything outside. Why did I do anything for my hemorrhoid?" So I have to hinge that whole hemorrhoid up. So what do? I apply purse string sutures. See, these are purse string sutures, and then I tighten them. So what happens? This whole master coming outside is now dragged up and hinged to the part above the pectinate line. So if you're doing arterial ligation, always do a mucopexis preferably, so that the patient has the psychological relief that he doesn't see any mass coming out anymore. So you're doing a mucosal fixation and lifting the hemorrhoidal cushions. So this cushion is lying now, which was lying out here, is now being cushioned up. It is lying upwards now, right? Right. So the MIPH is basically minimally invasive procedure for hemorrhoid. Use a stapler for that. I'll just show you in one figure what the stapled hemorrhoidectomy known as. Then you also got other names to it. STAR procedure, which is stapled transanal rectal resection. And this resection is basically different from MIPH. And that resection basically is for obstructed defecation, especially in those patients where the rectal length is slightly more. So along with the hemorrhoid, you're removing the whole rectum with the hemorrhoid. That's why it's known as rectal resection for obstructive defecation. Or you can do a procedure for prolapsing hemorrhoid or stapled anopexy, which you just not talked about. So MIPH, PPH, STAR are more or less the same procedure done at the same site, but with different objectives in mind. What are the complications? Bleeding, stricture, fecal incontinence. See, I've applied staples all around. This may become too tight, so they can be stricture. Or I've applied this staples out here, one of the staple gets loose, so bleeding occurs. Or fecal incontinence. I go very deep and I include this muscle. So when I include this muscle in this staple, what happens? Incontinence. Or I go too deep anteriorly in females, I take a part of the vagina in it. What do I create? A rectovaginal fistula. Chronic proctalgia, chronic pain, total rectal obliteration. I, instead of doing a circular stapling, I do something like obliquely, or I cut one part of the wall and one part of the wall here. That leads to what? A rectal obliteration. You'll not be able to understand this much better if you've seen it being done, but just remember rectal obliteration. Rectal wall hematoma, perforation pelvic sepsis, often requiring a diabetic stoma. I go high up and I do a cutting out here. I apply a staple out here, which cuts through the rectal wall, leads to what? A pelvic abscess. So a higher complication rate in reversals are expected after PPH for 4th degree pilus. So that tells you one thing, and that is that MIPH, STAR, and PPH are preferably done for grade 2 and grade 3, less commonly done for grade 4. See, this is what MIPH is all about. This is a pilus mask. This is a stapler. So I drag this pilus mask with the help of sutures. Let's not talk how it is done, but I've just dragged. See these piles inside the stapler? Can you see these? So they've been dragged inside with the help of sutures. These are sutures, right? And now I will close this staple, right? This is the anvil of this staple, and this is basically a cannula. So I am going to close it. When I close it, then I'm cutting all around. And when I draw it out, I'm leaving this behind. See the staples? So this is basically dragging the pilus mask inside the stapler, and then closing the anvil, and then removing everything which is lying inside the stapler, which is the pilus mask which has been cut, and I'm leaving behind a normal anatomy with the staples in place, right? So that is how it works. The complications of that was the stapler complications. So what are the complications? Hemorrhoidectomy, early complication hemorrhage. You can have anal stricture, anal fissure, abscess, fistula, incontinence, all known after hemorrhoidectomy. External hemorrhoids are basically varicosities in the external rectal venous plexus, anal tags, perineal hematoma. This is how they appear. 7-day self-curing lesion is slightly different. Perineal hematoma is nothing but a hematoma occurring in external hemorrhoid. It's self-limiting. Why? Because hematoma gets converted to fibrosis, and that's why it's also known as 7-day self-curing lesion. The patient comes to with severe pain, and there's a blue lesion at the margin, at the junction margin and the verge, right? So there you have this blue color lesion, and you know this is basically a hematoma which has occurred in the external rectal venous plexus, and that usually disappears. Or there has been gradual fibrosis. This patient will come to you like an anal tag. The treatment is very simple. That is, the patient is troubled by these tags or by the external hemorrhoid, just remove. But then you have differentiated from anal papillae, and you have differentiated that anal papillae always arise at the dentate line. This never arises at dentate line. This arises at the verge, right? So this is basically what is happening in external hemorrhoid. Anal strictures, non-malignant, the causes are senile, postoperative. I think go through the list. I don't think we need to go into the details of these, but just remember if it's a non-malignant, we talk about non-malignant, you can do a dilatation either with a finger, bougie or proctoscopy, or you can do anoplasty, or you can do an excision or anastomosis if you find that you cannot do anything with the help of these lesser invasive procedure for anoplasty or dilatation. Go ahead and do an excision. I think we'll talk about this next time. Just a small part left. I think we got. I think if you can just spare time for 10 more slides, I think you can go ahead and do this also. Otherwise, just have to waste one lecture for 10 slides. Just in very short, anal warts, also the condylomata acuminata. This is how it looks like. This is the anal opening. You see the anal opening. You see all these acuminata out here. These are the small papillae. And why is it important? Because this is basically a disease which has got a severe, a lot of problems with itself. And what are these? Number one, sexually transmitted disease caused most commonly by the human papillomavirus, HPV. And the most common causing the warts are HPV type 6 and 11. Almost 90% genital warts are because of this, right? And the spread is very important. Skin to skin contact occurring when? During oral, genital or anal sex with an infected partner. And what is important is that when you have such kind of a skin to skin contact, there is 70% chance that he or she will be infected. That means during contact, 70% will be infected, but only 1 to 5% of those infected will develop genital warts. That means the clinical manifestation will occur only in 5%. 70% gets infected, but 5% manifests with a clinical manifestation. But there's another thing important, and that is, remember that, and that is that the latent period, which is there when there's no clinical manifestation, that latency period could be spread over what? Months to years. And that patient can transmit the infection even during the latent period. That basically means that that person who's infected may not be having those lesions. You're sure that this patient doesn't have an HPV lesion and you have sexual contact with that person. But that patient could be in latent period. That means that those 5% of patients who manifested clinically, 65% would not be manifesting. Those 65% patients can still transmit. That is very important. Okay, so a latency period transmission from months to years is also there, and these viral particles basically penetrate the skin and the mucosal surface through microscopic abrasions in the genital area. So these are very small abrasions which occur during sexual activity, and that is why it can transmit. And this latency period is occurring for almost months to years or decades, even decades. Ultimately, the immune system of yours can clear the virus, but through interleukins. But at that point of time, until it is cleared, you are basically able to transmit that. Histopathology was happening above the skin surface due to enlargement of the dermal papillae, right? So basically, it starts occurring, infecting the skin surface, either lower third, middle third, or upper third. That was the current AIN. Just hear about the AIN. And what happens in the skin? Parakeratosis. Keratosis nuclear changes, which are enlargement and perinuclear clearing. And these are important histopathological manifestations of what? Of HPV infection. And how do you diagnose? Basically, a very easy method of diagnosing is with the help of aceto whitening or application of glucoside. You just apply it over the skin surface or the mucosa thought to be infected, and you find a white blanching. White blanching. Apply 3 to 5% acetic acid solution. There's a white blanching. And why does it occur? Because of increased cellular protein and increased nuclear density, right? So that white blanching identifies a particular area which can then be biopsy, right? So basically what you're looking at is a whitening of an area with the application of acetic acid, very commonly done for areas of cervical involvement, very commonly done for areas of mucosal involvement, now also very commonly done with HPV infection of the perineal area or perianal area. Okay, so that indicates the area where you need to take the biopsy. Now, symptoms in the early stages, nothing but pruritus, discharge, bleed, and pain. Initially, so subsequent to what happened? Pinkish white pigmented papillary lesions in the inoderm or anal wall. So initially pruritus, pain, bleed, and then these lesions start appearing, papillary lesions. And still later what happens? They may coalesce to give larger lesions which may always large growth, like for example, Bush-Lowenstein's tumor. Whereas you find Bush-Lowenstein's tumor, where we refer to this tumor where else? Benign. Okay, so just a few places. You also have in other places. So Bush-Lowenstein's tumor is nothing but a large coalesced papillary lesion. A number of them have coalesced, giving rise to this Bush-Lowenstein's tumor, right? So these anal warts, can they be prevented? You can't cure HPV as such. There is no cure. But Gardasil is a vaccine that protects against human papillomavirus type 6, 11, 16, and 18, which are responsible for most of the warts, and 16, 18 are also responsible for the anal carcinoma. So treatment, as far as there no cure, but you can basically prevent it from happening by these vaccines, right? So, but there are methods by which the warts can be cleared, and they reduce the infectivity, of course. 25% portofilin, laser ablation, electrocautery, surgical excision, imiquimod, that's a topical immune response cream, and then you can use ointment of catechins, trichloroacetic acid, and cryosurgery. These are basically just doing the external lesions. They're not curing the lesions for you, not curing it of the infection. If you look at the AIN, which is basically one of the pre-malignant conditions, anal intraepithelial neoplasia, I just now told you 6 and 11 with warts, and HPV 16, 18 with cancer. Always remember this. HPV 6 and 11 is non-malignant manifestation. 16, 18 give rise to malignant manifestation. Where do you find HPV? Most commonly in HIV and immunocompromised individuals. And what's happening? Dysplasia of the anoderm. And what dysplasia? We just now talked about that. Keratinocyte maturation. That is parakeratosis. Extension of proliferative zone from basal upward. So you have the basal layer involved, then you have the middle involved, and then you got the keratinocytes and the superficial layer involved. And based on that, you got AIN 1, 2, and 3. If you have the lower third of the epithelium involved, it is AIN 1. And you got the full thickness of the epithelium involved, it is AIN 3. And progression of AI1 to AN3 can occur. That can always occur. That means if you have AIN3, then you can always go on to AN1. You can always go on to AIN3. Right? What are the symptoms of AIN? Just like symptoms of HPV. It may be asymptomatic. You can find a surprise in a ward in 10 to 30%. You can find that these are dyskeratotic changes. You can have pruritus, pain, bleeding, discharge. We just talked about that. Originally seen as Bowen's disease of the anal region, but now they suggest that Bowen's term should not be used, right? So in AIN3, what do you find? This is the last stage of AIN. You find these wet, raised, white, gray patches, pigmented or fissured. And what is the relationship with cancer? Now, AIN3 is closely related to cancer in two forms. Number one, seen on HPE 80% of anal cancer. That means if you're doing a histopathological examination of a biopsy taken from anal cancer patient, be sure that 80% of these patients will be showing HPE lesion of AIN3. One. And number two, it is pre-malignant. And it is found that progression to cancer can occur in 10% in 5 years. So this is a close relationship. It tells you that AIN3 is related to cancer. And how do you treat it? AIN1, you can use imiquimod 5%. Anti-HPV treatment, this is just not talked about. Surgically, what is important is if you have less than 30% of circumference involvement, that means the whole of the margin of the opening, 30%, you can do an excision. But more than 30% or more widespread, you have to go in for a wide excision with a flap repair. This is how it looks like. See, normal, low grade AIN1, grade 2, high grade AIN2, and AI3. This is basically cancer, right? So it is basically the degree of involvement of the epithelial thickness, which is giving rise to 2 and 3. So this is the entire thing of the skin, AIN3, right? And that is why AIN2 and 3 are also known as high grade anal squamous intraepithelial lesions, right? HSIL. And grade 1 is known as low grade, so LSIL. Okay. Now, just the last topic, and that is anal cancer. It's not very much, just 4 or 5 slides. Epidemiology and predisposition, a whole range of epidemiological factors. You have the increasing trend all over. That is true now. We're finding more and more people with anal cancer. And what's the reason? Probably one of them is increasing HPV infection. More common in black males. Black males, remember, males is important. It's not in black females, right? HPV infected, HIV infected, multiple sexual partners. Anal intercourse, especially male to male intercourse. Post-transplant, 100 times more risk. See that? Smoking, 4 times more risk. And why is that? It interferes with your apoptosis progress. It depresses your immune system. Chronic immunosuppression, not due to HIV. So that means you have other cause of chronic immunosuppression, you have an immunosuppressive disease. Even you are more liable to have anal cancer. Crohn's with anal fistula manifestation. That means Crohn's without anal fistula is not increasing liable for anal cancer, but Crohn's manifesting with anal fistula is increasing liable to develop anal cancer. Right? Females 2:1. Right? And females, basically those who have started sex at an early age, who have had multiple sexual partners, having sexual partners who have had other sexual partners, there's a mix up, having uncircumscribed sexual partners. Or if the female has got a history of cervical, vulvar, or vaginal carcinoma. So all these are patients are more or less liable to have anal cancer. What about HPV? HPV, I said, more liable to have anal cancer. Just a few words of HPV. What is basically HPV? So it's a large family double-stranded small DNA virus, right? And that causes infection of the squamous epithelium. We all know that. So it is a DNA virus, large family of double-stranded small DNA virus. Okay. Why are they known as papillomavirus? Because some of the subtypes cause papilloma, that is warty condylomata accumulator like growths. That's why they're known as papillomas. And there are 100 subtypes. But among all these, anal cancers, HPV 16, and others which may be linked to anal cancers are 18, 31, 33, and 45. While 6 and 16 were more commonly related to wart formation. How do they spread? Skin to skin contact. We just not talked about that. Intercourse oral sex. We talked about that. I'm not going to repeat that. And prevention, if you're using condom, good preventive, but it is not 100%. Circumcision, not 100%. Abstinence, yes, a good method, right? Because WHO classifying anal cancers, you got anal canal and anal margin. And that's why we said last time in history, in anatomy, remember, anal verge, anal margin. So anything from anal verge proximal is anal canal. Anything from anal verge 5 to 10 centimeters beyond is anal margin. And they got different type of cancer. So anal cancers, 85% of anal cancers are squamous cell carcinomas, right? So anal canal cancer more common than anal margin cancer, almost 85%. Out of these, 75% of all anal canal are squamous cell carcinoma. And the four histological subtypes of squamous cell carcinoma: squamous, transition, basaloid or cloacogenic, and mucoepidermoid. These are all varieties of squamous cell carcinoma. Apart from SCC, what else can you have? Adeno. You can have melanoma. You can have a lymphoma. These are all inside the anal canal. What about the anal margin? They are all cancers arising from the skin. That means intraepithelial tumors like Bowman disease, which is a precursor of SCC. Paget's disease is a precursor of adenocarcinoma, right? Invasive tumors, these are intraepithelial invasive tumors like SCC, adeno, basal, varicose carcinoma. So this is basically WHO classification of anal canal and anal margin cancers. Now, where does the adenocarcinoma arise from? We all know it's basically squamous epithelium we're talking about, stratified squamous epithelium. Even the skin is stratified squamous epithelium. So basically, they can arise either from the anal glands. Remember, when we talk about anal glands, I told you this is basically an area which is there, giving rise to columnar epithelium and adenocarcinoma. The other in the skin, that is the anal margin, it could be the intraepithelial adenocarcinoma known as the extramammary Paget's disease. Arising from where? From the apocrine glands. So you got the apocrine glands in the anal margin, not in the anal verge, in the margin, yes. So arising from adenocarcinoma, right? Patients who are typically presenting just like pruritus, anal tenderness, bleeding, just like in either malignancy, nothing different out here. And physical examination, again scaling, tan-colored plaques in the perineum, again nothing differentiate from a squamous cell carcinoma. The treatment of Paget's disease is basically based on the biopsy reports. If you got underlying malignancy, do an APR. No malignancy, do a wide local excision. Is that clear? So that is basically the adenocarcinoma. Just talk about that in a future slide. Spread local, lymphatic, and hematogenous. Among them, the local is the most common. Circumferential involves the whole of the margin, causing narrowing. Stenosis, it will also involve the sphincter, and beyond the sphincter, now it goes and involves the issue rectal fossa. So that is circumferential and extension. So from the mucosa to the sphincter, and then beyond the sphincter, issue rectal. Lymphatic 10 to 15%, and we talk about the lymphatic pectinate line. Above goes the superior rectal, the sigmoid superior rectal, and below it goes where? To the inguinal. So below the pectinate line, inguinal. Above the pectinate line, it goes to the higher level bifurcation superior rectal artery. Right? Hematogenous, go primarily to the liver. Less commonly, you can have the lung, you can have the bone. And you can even have the brain and eyes also been reported in the literature. But remember, liver metastasis, most common, less common are the lungs and then the bone. Symptoms are again same. Bleeding has to be there. Differentiate from hemorrhoid. Discharge could be there. Obstructive defecation, if the growth is very large. You can find the growth by itself. You can fecal incontinence. You can have a retrovaginal fistula. And you have differentiated from a lot of other conditions in the local area. You have similar symptoms as fissure, hemorrhoid, dermatitis, and rectal fistula. So that has to be kept in the differential diagnosis, especially when you got a very early growth. Full-blown growth, no problems. Diagnosis, endoanal ultrasound, especially in very starting growths, detection is 100%. Depth of penetration can be seen in 75%, especially on sphincter complex. And then it can be used also to gauge the accurate response to this tumor after any type of therapy, especially chemoradiation. So how do you know the chemoradiation is effective? Do an endoanal ultrasound. Incisional biopsy with HP, yes. CT, yes. MRI is a very good modality and the same modality of choice for assessment of loco-regional disease staging. Right? So you want to have the T staging and you want to have N staging, one of the better methods to do it. PET scan, on the other hand, is useful when you have a tumor less than 2 centimeter in size. Initial staging helps with the staging. Post-treatment restaging of patient. I've done a chemoradiation and I want to restage the patient. A PET CT scan will help. Helps in differentiating between a residual viable and non-viable tissue. That means I have a chemoradiation, I still got growth. Now that growth is there, whether it is got a viable tissue or non-viable tissue will not be seen on an MRI or CT. Viability of particular tissue can only be seen by its metabolism, and metabolism can only be seen by a PET scan. So PET CT is very important when you want to differentiate viable from non-viable tissue, especially after some kind of therapy, especially chemo radiation. Staging depends on clinical examination, HP, and inguinal lymph node examination. Because the T stage, similar like in any other disease, 2 to 5, and more than 5, and then any size with a local spread to the surrounding area. Nothing different. N1, inferior rectal lymph nodes, N2, pelvic or groin, N3, rectal plus groin, or bilateral. Now, inguinal lymph nodes are very important in the sense that they are an independent poor prognostic factor for local treatment failure and long-term survival. So if you got an inguinal lymph node, you can easily say what is the prognostication of that particular patient is, right? Synchronous inguinal metastases are found in 10 to 25% cases, and metachronous is found in 5 to 25% cases. That means I've had a surgery for adenocarcinoma done today. The chance of me having inguinal lymphadenopathy later on would be almost 25%, 5 to 25%, right? M0, M1 fortunately seen only in 5% of patients. The manifestation with metastasis is seen only in 5% of patients with anal carcinoma. For the treatment, SCC and all its variants, that means basically the transitional, the squamous, the cloacogenic, the basaloid, and so on and so forth. The treatment is always chemoradiation, and that is the necros technique, and that is using a combination of 5-FU mitomycin C with a radiation of 45 grays to 60 gray radiation units, and a 5-year survival rate in the range of 70-90%, which is a very good 5-year survival rate. So we use this combination of chemoradiation, 5-FU mitomycin and radiation 45 to 60 grays, you'll have 5-year survival rate of 70-90%. Local disease relapse in 25%. Alternatively, you can use cisplatin doxorubicin instead of 5-FU mitomycin. Surgery, local surgical excision can be offered to those patients who have got a superficially invasive SCC. And how do you define a superficially invasive? A tumor that after complete excision with less than 3 millimeter basement membrane invasion and less than 7 millimeter of horizontal. That means down 3 millimeter, 7 surrounding. If it's got less than down 3 and surrounding 7, it is a superficial SCC. In those cases, going for local surgical excision. If there has been a recurrence after local excision, chemoradiation should be done. If there is a failure to respond, then salvage therapy with an APR with a colostomy can be done, or in stage M1 stage, you can do a colostomy for inoperable and non-responding patients. Adenocarcinoma, which we just now talked about, found in 10-20% of cases, second most common after SCC, more aggressive. You have to decide whether the adenocarcinoma you're looking at is a rectal adenocarcinoma or a anal adenocarcinoma. So how do you decide? The decision, why do you want to decide? Because that gives a different KNM classification. and the center of the tumor is 2 centimeter or more proximal to the anorectal ring, then it is a rectal carcinoma. If it is lying within 2 centimeter on either side from the dentate line, it is a anal canal cancer. So if you got a T1 tumor, local surgical excision can be done. All other tumors, neoadjuvant chemo radiation followed by radical surgical resection or APR has to be done. And when you talk about the prognosis, the tumor stage and grade differentiation are the most significant prognostic factors for survival. Look at the survival stats, T1 86 and T4 45, right? If you got N0 76, node positive 54. So overall, I would say this is not a very bad prognostic cancer if diagnosed early, which it usually is because it's an external manifestation with manifestations of pain and bleeding in that area, which immediately comes to notice. Then that's why it gives a very good survival stats, right? Now, just the last slide, and that is just a few words about how do you treat anal incontinence. Now, if you want to treat the anal incontinence, one, you can do a double breasting or divided sphincter. Suppose you did a fistectomy and it divided the whole of the external sphincter to a line separate. So you can take them together and do a double breasting. Do a double breasting of this, right? Now, that double breasting can help, but then that is not very beneficial in most of the patients. You can do a reefing of the external sphincter and the pelvirectal muscles, but the poor long-term results are basically working against this kind of therapy. You can do augmentation of anal sphincter, either surgically or simpler method. Now, if you do a surgical augmentation, that's effective in 60% of motivated. Okay, so now am I connected now? Hello, hello, can you hear me?
Yes, sir. Connected. Yes,
Okay,
sir.
okay. Okay, so we're talking about just a few words about treating anal incontinence. So one, you can do a double breasting of the divided sphincter end. So you got basically the ends you have cut through by fistectomy, and you double breast them and you basically unite them. So that is basically using absorbable sutures. You can do double breasting. Other thing could be reefing of the EAS or PR muscle. So basically it's loose. So what do? You do a reefing like this. So behind you do a reefing, so you're shortening it. So muscles like this and you connect like this, so that becomes short. That's reefing. But poor long-term results. Augmentation of the anal sphincters can be done surgically. It is effective in 60% of motivated. Why do we say motivated? Because you're doing another operation to bring a muscle trying to build up the anal sphincter. Like for example, a gluteus maximus transposition or a glacis sling operation. So the patient has to agree to this kind of an operation. That's why it has to be motivated person. And the results are only 60%. So that is again not a very successful, I say not a very successful. And that's why the newer simpler methods are now more in vogue. Use an inflatable silicone cuff, like for example, you use in urinary incontinence at the bladder neck. Similarly, here use it around the anal canal. Or you can use a magnetic sphincter. Or better, you can use a sacral nerve stimulation to the post-sacral foramina, where you stimulate the S234 and that stimulates the parasympathetic, and that basically helps you in the incontinence problem. So these are just methods of tackling anal incontinence. I think that brings us to the end of this lecture, and I think we've finished with the anal canal, and then I think we'll be touching upon the rectum and the endo pelvic fascia, which a lot of you were interested in, because it's an important part of the transverse fascia lying in the pelvic cavity. So if you have any questions as far as this lecture and other lecture are concerned, you can always go to the YouTube Prime channel, look up my name, or you can visit my website and you can find that basically you can be directed to that particular lecture. So all these lectures are loaded. This would also be loaded in the evening today, and you can look at some of the educational videos that I've uploaded. Any questions if you have, I'll be willing to answer them. Any questions? Okay, if you have none, I think thank you very much for your time.
Thank you, sir.